status of excipients such as PEG 400. And then I concluded my thesis by saying the results of these theses have implications for the use of PEG 400 in dosage forms. For example, when compounds are being considered for biowaivers, and also highlight the importance of gender studies in pharmacokinetics. And then it reminded me that to do this, I did a mini clinical trial with my healthy volunteers who were...
Your children again?
No, not my children. I didn't have children, although I got pregnant and had a child during PhD. But at that time, they were the other PhD students who were the volunteers. And they had to provide their urine sample over 24 hours. So I've got this image. I had this orange urine collector that I was famously known for at home. So they provided 24-hour urine, and then I'd analyze it. And then I created an HPLC method, which
In the kitchen?
Sorry?
In the kitchen?
Yeah. No, in the lab at UCL School of Pharmacy. So it's one of the things I reflect on because the method is still in use today. You know, when you do things for your PhD, you just think, well, you've got the information and that's the end. But that HPLC method, people are still referencing it. And also, part of the results of my PhD were recently put into a publication. And again, the findings that I had were proven 12 years later. But although I no longer work in clinical pharmaceutics at all, and in fact, I went straight back into hospital once I finished my PhD, the skills I gained from completing my PhD, including tenacity, are still in use today, as well as mentorship from my PhD supervisor, Professor Abdul Basit, and my relationship with UCL School of Pharmacy. So for me, it's cimetidine and PEG 400.
Okay, so just for the non-health professional listener, PEG is polyethylene glycol, right?
Yes, polyethylene glycol 400.
Okay, let's move on. What were you going to say, Paul?
One of the themes in this podcast is how things keep on coming back round. It sounds like you're a pioneer for pharmacogenomics. We talked about it recently as the next big thing, but you were writing PhDs about it, 12 years ago?
Yeah, that's interesting. I didn't think of it that way. And to be honest, because I'm not in that field anymore, I feel like I had to go back and read my thesis again. But no, I hadn't thought about it in that way. So thank you. I shall think about that some more.
I'm glad you enjoyed it, Diane, because I was thinking no wonder she went into antimicrobial after that.
Antimicrobials came by, it was not planned, but I am very pleased.
So you can definitely have that as your desert island drug, so cimetidine and PEG 400. What about a career anthem next then? Looking forward to this.
Well, I'm a Christian. 2 songs which reflect my faith. I know I haven't followed any of your.
You haven't followed, but don't worry, you're not the first not to follow.
So one is a hymn and one is a contemporary song. And the hymn is "Great Is Thy Faithfulness," which is a popular Adventist Christian hymn written in 1870, so a long while ago. It comes from the Old Testament, Lamentations 3:23, and they're just aspects from that within the song which reflect how I feel my career has gone and my life in general. And there have been multiple challenges that I've had over time. And when people think, how could you possibly go on and why would you still be interested or loving pharmacy? But I still do. So for me, my faith allows that. And the second one is Goodness of God by Bethel Music. And again, similar to that, I do feel that, yes, I do work hard, but I believe that the added impact, the added favor that I get is linked to the faithfulness of God and his goodness.
Do you sing then, Diane, in a choir or anything like that?
I have got a horrible voice. However, my daughter has a beautiful voice. Actually, both my children are quite musical and my husband, but my voice she tells me not to sing.
That podcast I was talking about, Just One Thing, one of the things that he does research into is singing in a choir. There's a lot of evidence about how it improves well-being.
I did join a choir once, but that was because they didn't have many people to join. And yeah.
So, Diane, I would love to be able to tell you that you're the first guest to have picked a hymn, but sadly, I can't tell you that because somebody has picked a hymn. So, would you go, which of the two, if we had to push you for one, because we like to go for one if we could, which one would you go for of the two?
Goodness of God, I would encourage, because It's quite upbeat and the words are beautiful. I mean, the hymn most people will know about, but Goodness of God by Bethel Music.
Cool. Well, we'll be able to put that into the Spotify Oral Apothecary playlist, so that's beautiful. Thank you very much for that. And the last thing is you get an opportunity to offer a book for the Oral Apothecary Library for the listener. So what would you like to offer for that?
The book I was definitely going to choose was Lean In by Sheryl Sandberg, but somebody else has chosen it. I think it was Sam Quay. So I'm not going to go for that one. I am going for Atomic Habits by James Clear. I've only actually recently read the book, but it validated some of the actions I've had from when I was much younger. For example, right from the first year of secondary school, I wake up at 5:30 in the morning and I've always been an early riser, and that was great for doing a PhD, and other habits I built in, such as learning how to touch type. But it also challenged me on other aspects. Very briefly, it talks about the fact that the small, tiny habits can actually have an impact on our lives, and that more than 50% of our actions on any given day are automatic actions and habits. So how do we build those so that the benefits or what benefit us? And it talks about 3 directions in which you can approach behavior change: outcome driven, process driven, or identity driven changes. So the identity, I'm going to focus on the identity driven one. Is basically trying to say to yourself, who do I want to become? And then having habits that match that. I'll explain to you how it links into my career soon. And so, for example, from a health perspective, for example, they give this example that if you want a 6-pack abs, somebody who wants that, they must have a healthy lifestyle. So you make that decision in your head, and then you desire to have a healthy lifestyle, and then you start to build on that, and you say that you will do X, Y, and Z. So for somebody, they could say they want to do 10 crunches before bed. So you can notice it's quite small. Low calorie diet, or riding a bike instead of driving to work. So they build that around things that they do to make it more sustainable. And then they do that over time. But the purpose of them is that they chose an identity of being healthy rather than I want to lose weight. For me, I recently had a rethink about how I wanted to move forward as I reached a significant age recently. And one of the things I said I wanted to become was the person who exercises consistently for 30 minutes a day. It's interesting. That sounds quite easy, but with the kind of busy life that I have, and I know everybody's busy, but with that, it was challenging. But I decided that actually that's who I'm the kind of person that wakes up in the morning and gets on the treadmill for 30 minutes. And I've always had that desire, but never really done it. So how did I start? Very small, 5 minutes, 1 minute, go for a walk. And then I did the couch to 5K. That helped for the second time. And actually I've been running 30 minutes nonstop since then, a few months ago. And then I did a 1 million step challenge as well during the summer. But anyways, how does this relate to the career? So I'm a pharmacist and I love pharmacy and I love sharing my practice. One of the soapboxes I get on is that we don't publish enough. How this is relevant is me building habits on how I share my projects through peer review publications and contributing to research regularly. That's who I want to be. That's the identity I want to have, is someone who shares practice and reduces duplication of efforts and also supports the profession.
Wow. James, I'm assuming you've read this book because you were nodding. Is that right?
Yes, yeah, very good. And all, stickered up with lots of things as I do.
That's one of my favourites. I've read that one.
And he's very good on Twitter as well.
He's got a good email, actually. If you subscribe to his email newsletter, it's very good as well. He also talks about, again, it relates back to this just one thing I was talking about. It talks about taking an audit of things that you do every day and then linking the things that you want to do to the things that... So, for example, everyone brushes their teeth twice a day. If you do sort of 10 squats every time you brush your teeth, it all sounds really simplistic, but it's actually really, really powerful. I've said before, I think I'm trying to write a book. How do you fit the time in to write a book when you've got a job and 3 kids and do a highly successful podcast?
Are you talking about yourself?
200 words a day is only sort of 10 lines and takes 15 minutes. But if you do that for 6 months, you've done 50,000 words, which is half a book. That cumulative gain is really, really powerful. And I don't think you realise how much it is until you actually put it into practice.
I do that for all sorts now, and even with my children, I say, what's the tiny bit? Let's start with something very tiny. Build the habit, then we can expand.
So it's only me that hasn't read it. So did you say it was called Atomic Habits by...
James Clear.
James Clear. Excellent. That sounds like a great book, actually. So we'll all have to take that one up. The thing about cleaning your teeth, though, we must all have done this as pharmacists. That's when you tell people to use their inhaled corticosteroid, don't you, before they brush their teeth? That's what I've always done anyway.
That's an example.
Okay. Excellent choices, Diane. Really enjoyed those. Thank you very much for that. And I think it's me introducing the micro discussion. So I'm going to try and do this briefly because normally Jamie tells me off.
I'll go make a cup of tea then, Steve, while you're doing that.
So I'm going to put this right out there, and I'm going to say I think this is one of the best editorials I've read this year, if not the best editorial. And it was in the July edition of BMJ Quality and Safety, one of my favourite reads, by Professor Carolyn Tarrant, who comes from out of University of Leicester. And as Jamie said, it's about antibiotic overuse, managing uncertainty and mitigating against overtreatment. And it's based on the fact that there is a study in the journal that month about interviewing doctors working in intensive care and how they find it difficult about trying to decide whether to prescribe antibiotics or not to what are very, very sick patients in intensive care. The rest of the editorial pulls out in a very broad sense about this idea that it's really hard, and there's what they call diagnostic uncertainty, and that some of these things, and we are always talking on the podcast about behavioural change and nudge and things like that, and it talks about this diagnostic uncertainty and how difficult it is for prescribers, and how they might have what they call anticipated regret if they don't do it. They have action bias, so they feel influenced by what everybody else they think is doing, and they have risk aversion heightened when you're making a choice on behalf of other people rather than for your own decision. And then it tries to talk about psychosocial strategies to reduce overprescribing. And I'm going to leave it there because I think some of those answers are going to come out. But Diane, what did you think of this editorial?
I thought it was excellent. I said who I wanted to become, which is around sharing practice. So I do read quite a few papers, but it's usually in the context of I'm writing an evidence review, I'm doing research about something, that's when I go out and search. But what reading this ahead of this made me realize is that we really need more journal clubs, because I thoroughly enjoyed the paper, and it was just really nice to just read a good article for not enjoyment, but just to learn. But I thought it was well written, and it really highlighted in a simple way some of the information we've been thinking about and know about, but they just articulated it so well. And also I really liked that they have the strategies and they articulate the strategies that can be used. And actually the co-author, Eva, is someone I know quite well. So I did send a message to say, your paper is being picked up by the oral apothecary. So I'm sure she will become a follower to listen.
Career highlight.
Yeah. So in terms of the diagnostic uncertainty, the anticipated regret is something that we previously called it fear of the unknown. That's how we often talked about it. And actually, we did do a survey of healthcare workers, which is a EU-wide survey. So across 30 EU, EEA states, and this is when the UK was still part of the European Union. And we found that actually 31% of prescribers said they would have preferred not to prescribe in the week before. And the reason for that was fear of patient deterioration or complications. And this links back to some of the highlighted diagnostic uncertainty about anticipated regrets, which is people are more afraid of if they didn't do something than if they took some sort of active action, and that if you're inactive, then it's a lazy decision, and that's more likely to cause challenges. And then that links to what they call the action bias, and then the anticipated. And then that's prescribers can be risk adverse. So those who are more willing to wait or to not do anything or to have a different approach are those who are less risk adverse. But then they highlighted some of the strategies that can help prescribers with overcoming some of those concerns. I valued the fact that they highlighted that actually we cannot just keep telling prescribers, don't do this. You need to give something else to replace that. And there are examples of where we've done that in the past. So they talk about active waiting as one example. One of the strategies that's been used nationally is the Treating Your Infection leaflet. And part of that at the time, which is this was developed in 2011, I think, in the first instance, was because we realized that patients wanted to leave with something and prescribers wanted to feel like they've done something. So it used to be called the non-prescription pad. And the idea being you have a prescription, you prescribe, you tell the patient what the indication is, how long it's likely to last for, warning symptoms, and then you hand over the non-prescription pad to the patient. So that's an action, which is one of the strategies that they recommend within the paper.
Yeah, they talk about active, as you say, reframing it, don't they?
We did work, didn't we? Was that you, Jamie? We did the delayed prescriptions and stuff like that. That was nearly 10 years ago, I think. That was a similar premise. I think it worked sometimes, but where it didn't work was because there was just an overwhelming compulsion to cash it in, and people did. You mentioned it in your feedback there, Diane. It says, one of the lines I underlined was, research shows that regret is higher for acts of omission than those of commission. And that not only applies to antibiotics, it feeds right back into what we were talking to with James last episode, doesn't it? Around deprescribing and why people find it so difficult. They feel more regret for something they haven't done as opposed to something that they have done. It sort of says what this paper says. The vast majority of the strategies we're employing at the moment are probably doomed to failure. If you follow the logical conclusion.
I don't think they're doomed to failure. I think, because we highlighted, things like the non-prescription pad, which is that active information giving. I think what it does do, though, is pull it together within a behavior change strategy. And I think we need to amplify and be clearer to prescribers why this is what we're doing, why we recommend things. I think that would help. I particularly liked also how they gave examples from cancer treatment to say that, there is the active surveillance, or I think that's what they called it, where you actively monitor the patient as a way. So with delayed prescription, sometimes that active monitoring may not be as obvious for antibiotics and for infections. But actually, if we could frame that and say, this is what the things you need to monitor, then actually that might help as well.
It made me think about, remember when Mark Torbert ticked me off quite rightly in an episode when I used the word ceiling of treatment in palliative care? And he said to me straight away, we don't use that term. There should never be a ceiling of, there might be a ceiling of treatment, but there should never be a ceiling of care. And so again, it's the framing, isn't it? Which is a bit like the nudge thing about using the right words rather. Watchful waiting is what they used to say. Now they call it active cancer